So what we know from the Ernst & Young high-level analysis is that there's cost reduction potential in all 13 services. And given the fact that we're working with government to get back to balance and minimize the impact on patient care, we will be looking at all 13 services, as well as other services as well. So what we're looking at is trying to reduce the cost of running the DHAs so that we can protect the impact on patient care.
So if you're going to reduce in all 13, what's the point of having a short list of 6 if you're going to cut from all of them? I don't understand that.
Well, we looked at it in terms of the and again, not trying to prejudge what the conclusion would be, but a manageable number of services that we could do implementation plans for. So we felt the CEOs that 6 was a manageable number. But again, we're looking at cost reduction potential in the other services as well, because if we can save in administrative and support, again, it's another effort that we can use to minimize the impact on patient care.
So but of the 13, these 6 will see the largest reductions in services.
Well, the 6 that are identified had the greatest cost reduction potential based on the analysis that was done.
What does that mean? Sorry.
It means as the consultants compared our performance on each of these 6 services relative to best practice, it was the biggest gap. So our services were more expensive to operate than what best practice suggested.
Could you explain best practice? I hear that a lot, and I really don't know what that means in terms of it's the best way to do things?
It's both. Well, it's the best way to do things, but it's the lowest cost, best quality. And that's the way that we've approached this in terms of the lowest cost to provide in service, but maintaining or improving quality.
So the public might say, do we really need 9 presidents of DHAs or those sort of things? When you're talking about executives disappearing, perhaps yourself even, is that what we're talking about?
Certainly the executives are in scope for this review. That's entirely correct. So when we look at the potential impact on staff, it's the impact on executives, the impact on management, and the impact on bargaining unit. What we do know from the work that Ernst & Young has done in other provinces is that this type of implementation proportionally has a more negative effect on the executives and on the management than it does on the bargaining unit. So if you
sorry, go ahead.
Go ahead.
Have you considered getting rid of some of the DHAs?
That's not my decision to do so. The government's position is that, and the way that the study was approached is that all 9 district health authorities in the IWK were in scope. The structure was to remain the same. In terms of decisions that may be made around DHAs, that's really the District Health Authority Actress Administrator's purview.
And if I work for one of these 7 that aren't on the short list, say library services, I shouldn't take any solace in the fact I'm not on this short list. I could still lose my job, is what you're saying there today.
The job impact could extend into those other 6 services, correct, yes. 7 services, correct.
And are budgets tight currently as they are? And how, if they are, then how is this not going to affect patient care?
Well, the budgets are tight. In the year that we're in now, the 11-12 year, it was a status quo budget, which meant that the health authorities had to absorb cost pressures related to inflation. Government did pick up any settlements that were over 1%, but we had to pick up the cost pressure. So yes, budgets are tight, and budgets are going to be tighter next year in terms of the -3. So what we've been doing is focusing on the non-direct clinical care aspects of what we do in terms of the operations and support. And when we looked at these 13 services that were in scope, based on initial research we had done in terms of consultations with a number of colleagues across Canada who had implemented similar services, we knew that these 13 services had the greatest cost potential, and we knew that these 13 services, in all likelihood, had the minimum impact on quality care. But we will not be able to answer those questions in Nova Scotia until we finish the examination process.
So, Pat, it can't be easy to stand up here and talk about this today. And now you're saying your staff are worried across the province. What are you telling staff members?
What we're telling staff members is that, first off, we're being open and transparent in terms of where we are in the process. As we set this process up, communicated to staff that we would inform them where we are with respect to specific milestones in the project. We're telling staff that we will follow collective agreements if you're in the bargaining unit. We're telling staff that we'll follow established terms and conditions if you're in management. But also very importantly, we are acknowledging this is a difficult time. It's stressful and it's anxiety producing for all levels of staff, executive, management, and bargaining.
Are there unionized employees in all of these service areas?
Yes, there are. Yes, there are.
That's in all 6 and all 13?
That's correct.
And sorry, so you said in all 13 areas, there's 3,000 employees, is that what you said? Is that
Approximately 3,000.
for the 13
Yeah.
province?
You'll notice, well, that includes HITS Nova Scotia, that includes the HASP office we're currently in now. So again, not just those specific staff that are working in the DHAs, it includes other staff as well, and I draw your attention to that.
Could you just briefly explain supply chain, material management, what would that comprise?
That's our purchasing of supplies and services. Now you recall, you may recall last January we announced that as part of a strategy to further reduce our administrative costs, we went to one, what we call group purchasing organization, a bulk purchaser for the province, Health Pro. And with that initiative, as well as some other initiatives in terms of standardizing some clinical services particularly, we've saved or have the potential to save approximately $4.8 million already. So this is a continuation of that process to standardize processes and systems in order to maintain quality, improve quality, and reduce cost.
And are you looking at centralizing some of these things, maybe doing them on one health authority and branching out to the rest, or?
I'll remind you the process is to wait for the Ernst & Young recommendation, and certainly centralization is one of the possible alternative service delivery models. What we're asking to do is to identify the best practice service delivery model. Who in Canada is doing it best, and if we were to implement it here in Nova Scotia, what could the cost reduction potential be, and what could the impact on quality be?
And when does Ernst & Young report back?
Towards the end of December, and at that point in time, the report will be received by the steering committee. There's a steering committee of executive staff among the DHAs, and the Department of Health and Wellness will receive that report. The steering committee, which I chair, will make a recommendation to CEOs after our review to make sure that it certainly achieved all the deliverables that we set for this project, and then a recommendation to government in the new year.
So you're not bound by what Ernst & Young comes back, you can project or?
Ernst & Young is making recommendations, so we are not bound by.
You're on a timetable here. Just when does the steering committee receive when do you hear back from Ernst & Young? And when do you actually report the new?
We anticipate receiving the report on or about December the 21st.
December 21st, okay. And then what day do you expect to inform the minister about we'd like A, B, C, and D?
Once the CEOs have reviewed the report in the new year, then there'll be a report given to the minister and a recommendation to the minister. And after that point in time, that will go to government for review and
Can I press you for a day? Do you know when in January you're expecting to get that to her?
no, I don't.
But you're expecting like before the 15th. I take when you say early in the new year, it's January.
I said it'd be the new year. I don't know the date.
Okay.
Could it go into February?
It'll be the new year. I don't know the date.
Well, New Year could be next December, right?
Well, it'll depend on when the minister is available to receive the report, when it can get on the proper government agendas in terms of review, so that is beyond my control. I do know that the steering committee will be receiving the report on or about December the 21st, onto the CEOs in the new year, and then on to government. At that point in time, we're on government's timetable, not ours.
And the budget is starting April, is that first?
The fiscal years go from April 1st of one year to March 31st the following year, yes.
So we could see cuts in these district health authorities before April 1st? That's for sure?
It's not for sure, no. But again, we are following a three-step approval process. So once the report is received, everybody, that's three-step process in terms of approval is completed, then we would be in a position to announce the implementation plan and the implementation schedule, only after government approves the plan.
But the 3% deduction begins
April 1st, correct.
And you would expect to have these steps implemented as part of that. Isn't that the whole point, is to make it on time? So you're talking about what you decide to do is March 31st onward.
Well-
It's to align with the budget, I assume.
Government has informed the CEOs and other stakeholders as well that any savings that may arise from this project can be applied against the -3.
Right. Starting in 12-13.
Correct.
And then if the reductions don't match dollar for dollar, then hospital districts will just run a deficit, is that?
No, hospitals will not run a deficit. District health authorities will not run a deficit. The position from government is very clear. They expect us to operate on budget. So running a deficit is not an option.
So do you expect the entire 3% to come from this exercise, or?